You know, um, usually when you hold a prescription pill in your hand, right, like one of those tiny, perfectly round, mass-produced little tablets, you just kind of assume its origins are equally sterile and tidy.
Oh, definitely. Yeah, the expectation is always this very clean, linear process of modern engineering. People just assume we, identify a disease, build a molecule in a lab to fix it, and mass produce it.
Right, exactly. You picture pristine, white laboratories, maybe some supercomputers, some bubbling beakers. But welcome to this deep dive, because today, our mission is to explore a fascinating and, honestly, lately somewhat controversial class of pharmacology.
Yes, and we're talking about leukotriene modifiers.
Right, and these are the pills taken by literally tens of millions of people to control asthma and allergies. They basically serve as this, like, chemical roadblock for a massive, invisible inflammation pathway in your body.
Which is a huge deal for anyone who struggles with breathing.
Oh, for sure. But the origin story of this specific everyday pill, it doesn't start in a sterile corporate lab.
Huh?
It actually starts in 1938 in Australia with a piece of guinea pig lung tissue and, of all things, a highly venomous cobra.
Yeah, which is just a fantastic reminder of how wild the history of medicine actually is. I mean, our goal today, using medical texts, historical pharmacological records, and FDA regulatory history, is to understand not just what these drugs do when you swallow them.
Right, we want the whole story.
Exactly. We want to understand the incredible 60-year scientific journey it took to figure out why they work in the first place. And perhaps even more importantly, the 20-year regulatory reckoning it took to fully understand their risks.
Okay, let's unpack this because the contrast between the everyday reality of just, popping a chewable cherry-flavored asthma pill and the absolute wild origins of this discovery is just too good.
It really is.
Like, how do we possibly get from asthma to cobra venom? Take us back to 1938.
Right. So we are in Australia. Two physiologists, Wilhelm Feldberg and Charles Callaway, are running some experiments. They are studying venom, specifically how it damages cellular structures.
Okay, makes sense.
And during one of these experiments, they expose guinea pig lung tissue directly to the venom of a cobra. Now, based on everything known about allergic or toxic reactions at that time, there was an expectation of an immediate violent reaction.
I mean, yeah, I would assume so. If I get a bee sting, or like if someone with a peanut allergy eats a peanut, the swelling happens in seconds.
Right.
That's just histamine reacting.
Right. That is the classic histamine response. It's a very fast-acting chemical messenger. It triggers rapid spasms and sudden swelling. But that is not what Feldberg and Callaway observed under the microscope.
Wait, really? What did they see?
Well, the venom didn't trigger a fast spasm at all. It actually triggered the release of some mysterious substance that caused a very slow, highly sustained contraction of the smooth muscle in the lung tissue.
Oh, wow. So not a fast twitch.
Exactly. It wasn't a quick twitch. It was this long, relentless squeeze.
So they are staring at this lung tissue, watching it just slowly clamp down, and they realize, wait, we have discovered a completely new chemical reaction here. Did they even know what it was?
They had absolutely no idea. I mean, they didn't know what the chemical structure actually was because they could only observe its biological behavior. They gave it a purely descriptive name.
Which is very scientist of them.
Very on brand. They called it slow-reacting substance, which eventually became known in medical literature as slow-reacting substance of anaphylaxis, or SRSA for short.
SRSA. Okay, I love this detail from the historical records because for decades after that cobra experiment, nobody could figure out what this chemical actually looked like under a microscope.
Decades. It was incredibly frustrating for them.
It really makes me think of like an invisible ghost haunting a house. Scientists could see the doors slamming. They could see the furniture being dragged across the floor, which, in this case, is the muscle contractions happening in the lungs.
Right, the actual physical symptom.
Yeah, but they couldn't actually catch the ghost to see what it looked like. They just saw the damage.
That analogy captures the frustration of the scientific community perfectly, actually. SRSA was defined entirely by the damage it caused. You had this powerful inflammatory ghost haunting the human airway, and it literally took over 40 years to finally trap it.
40 years?
Yeah, it wasn't until 1979 that the chemical structure was definitively identified.
And this happens on the completely other side of the world, right? In Sweden.
Exactly. In Bengt Samuelson's laboratory at the Karolinska Institute, his team was doing deep research into how cells break down certain fats, specifically something called arachidonic acid. And they finally managed to isolate and map the elusive SRSA.
And what did they find?
They discovered it wasn't just one single ghost, but a family of closely related compounds.
So how did they jump from the name SRSA to calling them leukotrienes?
It basically comes down to the chemistry and the source. Samuelson noted that these molecules had a specific chemical structure called a triene, meaning they had 3 conjugated double bonds.
Okay, triene.
And because they were first successfully isolated from white blood cells, which are known medically as leukocytes, he just combined the 2 concepts. Leukocyte and triene gave us leukotrienes.
That's actually pretty elegant. And catching this molecular ghost was such a massive deal for medicine that Samuelson actually shared the 1982 Nobel Prize in Physiology or Medicine for it.
Oh, it was huge. Identifying that structure fundamentally changed pharmacology. Once chemists knew the actual physical shape of the molecule, they finally had a target. You can't build a lock unless you know the shape of the key.
Right, that makes total sense.
And that breakthrough in Sweden directly paved the way for the first FDA approvals in 1996 for the anti-asthma drugs Xyloton and zafirlukast.
But finding that molecular structure didn't just give drug companies a target, though. It also allowed scientists to trace exactly where this ghost comes from in the body's cellular machinery.
Yes, the actual origin point.
Right. And to understand how these pills actually stop asthma, we really need to dive into the biochemistry here. And it all revolves around this massive biological fork in the road.
Yeah, the technical term is the arachidonic acid cascade, which I know sounds incredibly intimidating, but it is fundamentally just the story of how your cells respond to being disturbed.
Okay, let's break that down.
Sure. So imagine a cell membrane in your airway.
Okay, I'm picturing the lining of my lungs, just a normal cell wall.
Now imagine that cell gets disturbed. Maybe you inhale an allergen like pollen or pet dander, or maybe it's just a harsh mechanical trigger like stepping outside into freezing cold air.
Okay, so the cell is irritated.
Exactly. When that membrane is disturbed, an enzyme acts kind of like a pair of molecular scissors. It snips a fatty acid called arachidonic acid free from the cell wall.
So this fatty acid, this arachidonic acid, is now just floating free. Where does it go?
Well, once it's clipped free, it faces a literal biochemical fork in the road. It has to go down one of 2 enzymatic pathways. The first path is called the cyclooxygenase road, which is often abbreviated as the COX road.
Okay, wait, the COX road actually sounds familiar. This is the pathway that creates prostaglandins,
Yeah.
right? Like the things that cause pain and fever.
Yes, exactly.
So if I have a pounding headache and I take an NSAID, like, ibuprofen or aspirin, I'm essentially setting up a giant roadblock on that COX road.
That is the exact mechanism of ibuprofen, yes. It blocks the COX pathway. But that free-floating arachidonic acid has a second option. It can travel down the lipoxygenase road.
The LOX road.
Right. This path is controlled by an enzyme called 5-LOX, which also uses a helper protein named FLAF.
FLAC. What does that even stand for?
It stands for 5-lipoxygenase activating protein. You can just think of it as like a molecular scaffolding that holds everything in place so the 5-LOX enzyme can actually do its job.
Okay, so if the acid goes down the second road, the LOX road, what happens?
If it goes down this road, it gets converted into leukotrienes. And within that family, there is a specific subset known as cystenyl leukotrienes. They're often labeled in textbooks as C4, D4, and E4.
And these are the bad guys for asthma.
These are the heavy hitters driving the severe pathology of asthma, yes.
Because reading the pharmacological data on these specific leukotrienes, it's just mind-blowing. They aren't just a mild irritant.
What's fascinating here is the sheer scale of their potency. Molecule for molecule, cystenyl leukotrienes are roughly 1,000 times more potent than histamine at constricting your bronchial smooth muscle.
Wait, what? 1,000 times stronger than the stuff that causes a bee sting reaction?
1,000 times. And they do far more than just constrict the muscle. They also increase vascular permeability.
Which means what, exactly?
It means they cause your blood vessels to leak fluid into the surrounding tissue, which creates massive swelling or edema. And on top of all that, they stimulate extreme mucus secretion.
Oh, wow. Which perfectly explains why a severe asthma attack isn't just like a mild wheeze. It feels like a genuinely obstructed airway because it literally is obstructed.
It is entirely blocked off.
You have this classic triad, right? The bronchospasm is physically squeezing the tube shut from the outside. The swelling is thickening the walls on the inside. And then all that extra mucus is just plugging up whatever space is left in the middle.
It's a total siege on the airway, and it's orchestrated by this one specific chemical pathway.
I need to jump in here and address a massive misconception, actually. Because if you tell a friend you're taking a pill for allergies or asthma, like montelukast. People often just assume it's a heavy-duty antihistamine.
Not all the time.
Right, like they think it's just a stronger version of Claritin or Zyrtec.
Yeah.
But based on this biochemical fork in the road we just talked about, that's entirely wrong.
They are pharmacologically completely unrelated. Montelukast has absolutely zero activity at histamine receptors. Histamine and antihistamines operate on an entirely separate biological highway.
They aren't even in the same neighborhood.
Not at all. Even some medical professionals occasionally fall into the trap of assuming an allergy pill just defaults to being an antihistamine. But when a patient takes montelukast for allergic rhinitis, it works exclusively by blocking cystine-leukotrienes.
Knowing about this biochemical fork in the road, the COX pathway and the LOX pathway, it really brings some bizarre, highly specific medical conditions into focus.
It explains so much of what we see in the clinic.
Because there are ways people experience asthma in the real world that seem baffling until you look at the plumbing. Let's look at aspirin-exacerbated respiratory disease, or AERD. I've also seen it called Samter's triad in the sources.
Yes, AERD affects roughly 7% of all adults with asthma, but it actually jumps up to 15% for those with severe asthma.
That's a huge chunk of people.
It is. And for these specific individuals, taking a completely normal over-the-counter dose of aspirin triggers a terrifying reaction. They experience acute bronchospasm, severe nasal congestion, and a sudden, massive asthma attack.
Here's where it gets really interesting. If we go back to that fork in the road, AERD is exactly like a river splitting in two directions.
Okay, like this.
You have the cellular water, the arachidonic acid flowing down. It can either go down the COX river or it can go down the LOX river. If someone with AERD takes aspirin, they're essentially building a giant concrete dam that completely blocks the COX river, right?
That is a brilliant way to visualize it. Yes. By taking aspirin, they shut down the cyclooxygenase pathway entirely. But the arachidonic acid substrate, the water in your river analogy, it doesn't just disappear.
Right, it has to go somewhere.
Because that dam is there, all of that cellular fluid is violently forced to flood down the lipoxygenase river instead.
So it forces all the traffic down the LOX road, creating this massive, unnatural surge of leukotrienes, which just immediately slams the airway shut.
The system gets entirely shunted to the inflammatory pathway. And this mechanism explains exactly why doctors specifically prescribe leukotriene modifiers like Xyloton or montelukast for AERD patients. The entire goal is to blunt that specific chemical flood.
It isn't just aspirin that causes these sudden surges either, is it? The environment can trigger it too. Specifically with exercise-induced bronchoconstriction, or EIB.
Yes, absolutely.
Say you're out for a run in the middle of winter. The air is cold and dry, that freezing air hits your airways, and it causes something called mast cells to degranulate. What does that actually mean for the runner?
Think of a mast cell as a microscopic water balloon filled with inflammatory chemicals, and it's parked right in the lining of your lungs. When the cold, dry air irritates them, they degranulate, which basically means the water balloon just bursts open.
Oh, gross, but accurate.
Within minutes, they dump a huge burst of leukotrienes directly into the tissue.
Which is exactly why you get that sharp, painful drop in lung function right after you finish a hard run in the cold. It isn't just being out of breath, your lungs are actively swelling. And taking a leukotriene modifier steps in to stop this.
This is actually an area where these medications truly shine. A single evening dose of montelukast provides roughly 24-hour coverage against that exercise-induced drop.
So you don't have to plan your whole day around it.
Exactly. A patient doesn't need to time their medication perfectly and take a pill right before they step on the treadmill.
So how do the different pills actually intervene here? Because reading through the pharmacology text, they don't all attack the problem the exact same way, do they?
No, they don't.
You have the 5-LOX inhibitors, represented by a drug called Xyloton, which is sold as Zyflo. And then you have the cystine-leukotriene receptor antagonists, usually called LTRAs. And that group includes montelukast, famous as Singulair, and zafirlukast.
Right, so they attack the leukotriene problem from two distinct angles. Xyloton acts upstream. It travels right to the 5-LOX enzyme factory, remember that chemical pathway we discussed earlier, and it just shuts it down. It stops the body from manufacturing leukotrienes in the first place.
It stops the factory.
Yes. Montelukast and zafirlukast, on the other hand, act downstream. They let the body keep manufacturing leukotrienes, but they travel to the airway smooth muscle and block the receptor, specifically the CySL-T1 receptor.
Ah, I see. So they essentially change the locks on the doors of your lung cells. The leukotrienes are floating around, but they can't get in to trigger the muscle contraction.
That is the exact mechanism.
Okay, so I have to ask the obvious question here.
Yeah.
If these drugs are so targeted, And if they are blocking a chemical that is 1,000 times more potent than histamine, why aren't they the absolute, undisputed, #1 cure for asthma today?
It's a very fair question.
Like, if I have a single chemical causing a 1,000-fold reaction, blocking it should solve the problem forever, right? But people still use inhalers everywhere.
It is a totally logical question, and honestly, for a while, the medical community thought they might be the ultimate solution. In the late 1990s and early 2000s, these drugs had a golden era. Asthma prevalence was rising sharply, and doctors and patients desperately wanted an oral alternative to inhaled corticosteroids.
Oh, I can imagine. I mean, anyone who has ever tried to get a toddler to use a noisy, scary inhaler with a face mask and a spacer, it's a daily nightmare.
It really is.
The idea of just handing a kid a chewable, cherry-flavored pill once a day was incredibly appealing to parents.
The convenience factor really cannot be overstated. The adherence rates for a simple daily pill are always going to be higher than for complex inhalers. But modern medicine doesn't run on convenience, it runs on data.
Right.
And eventually, the data started rolling in from long-term head-to-head comparison trials.
These were the major NIH-funded care network studies, right?
Mm-hmm.
They put montelukast monotherapy up against low-dose inhaled corticosteroids to see which actually worked better in the real world.
Yes, and the findings across multiple large randomized studies in both adults and children were just undeniable. Inhaled corticosteroids are simply better at managing the disease.
What way?
They are more effective at controlling chronic airway inflammation, they result in better daily lung function, and they are significantly better at preventing severe asthma exacerbations.
But why is an inhaler better if the pill blocks this incredibly potent ghost molecule?
Yeah.
Like, what's missing?
It comes down to broad versus narrow targeting. Leukotriene modifiers are snipers, right? They target just one specific biological pathway. But asthma is a complex, chaotic disease involving many different inflammatory mediators.
It's not just the one ghost.
Exactly. Inhaled corticosteroids work broadly across many of those pathways at once. And because of this solid evidence base, major asthma guidelines like GINA, the Global Initiative for Asthma, actually demoted these pills.
So the idea that a leukotriene pill is an equal substitute for a steroid inhaler is a complete myth.
If we connect this to the bigger picture, this entire story is a textbook example of how modern medicine actually operates over the long haul. It relies on continuous, rigorous clinical trial data to constantly adjust how we rank and prescribe treatments.
The science evolves.
Always. A drug can sound perfect on paper based on its mechanism, but the long-term clinical data always has the final say. Today, these pills are positioned as an alternative or an add-on therapy, not the first line of defense.
And what happened to Xyloton? You mentioned it stops the factory upstream, which sounds like the superior method, but I almost never hear about anyone taking it.
Xyloton is a classic case of theoretical superiority losing to practical reality. Blocking the pathway higher up is chemically elegant, sure, but in reality, the early versions of Xyloton required patients to take a large pill 4 times a day.
Well, that's a lot.
It is. Furthermore, it carries a real documented risk of liver toxicity, meaning patients require regular blood draws to monitor their liver enzymes.
Nobody wants to do that just for an asthma pill.
Exactly.
Yeah.
When you place that burden next to montelukast's simple, once-a-day dosing with no liver monitoring, Xyloton basically lost massive market share overnight. It became a very niche option for severe cases.
Wow. But it wasn't just a matter of efficacy that changed how these drugs are viewed by doctors today. It was also this slow burn, deeply concerning realization about their safety profile. Let's move from the lungs to the brain and talk about the dark side of post-marketing surveillance.
The biggest controversy surrounding this entire drug class is psychiatric safety. Almost from the time montelukast reached wide use, troubling case reports began accumulating.
What kind of reports?
We're talking about severe agitation, incredibly vivid nightmares, aggression, depression, and, in rare but alarming cases, suicidal ideation and behavior.
And this was being seen disproportionately in children and adolescents, right?
Yeah.
The exact demographic taking those cherry-flavored chewables. But reading the regulatory history, it is staggering how incredibly difficult this was to definitively identify.
Isolating drug side effects in a complex disease is notoriously hard. Think about it. If a patient has uncontrolled asthma, they are constantly waking up gasping for air.
Right.
They aren't sleeping well, which naturally causes behavioral issues and agitation. Furthermore, they might be taking bursts of oral steroids to control flare-ups, and steroids famously disrupt mood and sleep.
It becomes almost impossible to disentangle causation from all those confounding factors. Like, Is the terrifying nightmare caused by the montelukast pill, or is it caused by the sheer physical anxiety of a child not being able to breathe at 2 in the morning?
Exactly. It took years for regulatory agencies to filter the true signal from all that noise. The FDA first added a precaution about neuropsychiatric events to the montelukast label back in 2008.
But the timeline of what happened next is wild to me. The drug was approved in 1996. The precaution was added in 2008. It wasn't until March 2020 that the FDA escalated this to a boxed warning.
Which is the FDA's absolute strictest warning.
Right, but we need to clarify something here, because a boxed warning does not mean montelukast is banned, does it?
No, it is not banned. The boxed warning changed the drug's recommended positioning. It essentially mandates that montelukast should be reserved for patients who cannot tolerate or do not respond to other therapies,
Okay, so it's a last resort kind of thing.
especially for milder conditions like seasonal allergic rhinitis, where much safer over-counter alternatives exist. It does remain widely prescribed for severe asthma and AERD, where the breathing benefits clearly outweigh the psychiatric risks. But it now requires a very serious, mandatory doctor-patient conversation about mental health before the first pill is swallowed.
So what does this all mean? How does a drug taken by literally tens of millions of people globally take 24 years from approval to get the FDA's strictest warning?
This raises an important question about the vital role and really the inherent limitations of drug safety science. A drug's true risk profile is never fully known the day it hits the market, even after massively successful clinical trials.
Because the sample size is just too small.
Yes, a clinical trial might monitor a few thousand people for a few months, but when you roll a drug out to tens of millions of people over 2 decades, rare but severe side effects that were statistically invisible in the trial data will eventually surface.
It is a really sobering reminder that post-marketing surveillance isn't just some bureaucratic formality. It is an active, ongoing, real-world phase of a drug's testing. It really makes you pause before you swallow any new pill, knowing you are essentially part of the ongoing data collection.
It definitely highlights why both patients and doctors must remain vigilant, even for medications that have been on pharmacy shelves for decades.
So let's recap this incredible, sweeping journey for you, the listener. We started with guinea pigs and cobra venom in a 1938 Australian lab, which revealed a mysterious, slow-acting muscle contractor. That invisible ghost haunted scientists until a Swedish lab mapped the leukotriene structure, earning a Nobel Prize.
A monumental shift in pharmacology.
Truly. We explored the biochemical fork in the road, how an irritated cell can flood the lipoxygenase pathway and cause asthma symptoms 1,000 times more potent than histamine. We saw how rigorous clinical trials brought these drugs down from their 90s pedestal as a miracle cure, proving inhalers were still superior. And finally, we look at the sobering reality of the FDA box warning that took over 2 decades to arrive.
It's an incredible story of pharmacology, but here is a final forward-looking thought derived from the medical literature for you to mull over. We've talked exclusively about the lungs and the airways today, but researchers have noted that one specific molecule in this family, leukotriene B4, is heavily implicated in atherosclerosis and cardiovascular inflammation.
Wait, you mean like plaque buildup in heart disease?
Exactly that. Currently, there are no approved 5-LOX inhibitors designed for heart disease. But it forces us to ask, could the next major breakthrough in preventing heart attacks or even reversing chronic cardiovascular disease come from manipulating the exact same biochemical pathway scientists discovered by watching asthma and cobra venom? The clinical story of this pathway is far from finished.
That is just incredible. The next time you hold a simple, everyday pill in your hand, whether it's an aspirin or a daily allergy tablet, take a second to ponder the interconnected, hidden pathways inside your own body. You might just be dealing with the ghost of a cobra venom experiment. Thanks for joining us on this deep dive. See you next time.